So yeah, Dr. Sykes, thank you so much for letting us interview you today, and we're so excited to hear your story. As you know about the project, we would love to know about your background, who you are, and where you come from.
Mm-hmm. So, well, I feel like I come from here now because I've been here for so long in Oakland, but I came to Oakland from training in OBGYN back east in Massachusetts. And I had lived back east mostly in Seattle, grown up in Kansas City, and born back east near New York. So a little bit of everything. And then when I landed here, I've just stayed for 37 years.
37 years.
Yeah. And I came to La Clinica as a National Health Service scholar. So I was one of the very lucky ones in 1979 when I started medical school to apply for and get a National Health Service grant. And my intent, medical school was a bit of a U-turn for me after college. I had thought I was going to study marine biology. And I did that for a year in Maine, and then I realized I really wanted to work with people, and I especially wanted to work with women. And it was a time in throughout the 70s, late 60s, of a lot of increased consciousness about healthcare, women's rights, of course, and also women's health. And the community health movement was also developing in that time, which is very relevant to your project. And so I decided that I just really was going the wrong way and really wanted to do medicine, even though I tried to avoid pre-med students in my entire college career and couldn't imagine I was going to do that. But and so that's why I went into medical school and applied for a national health scholarship because I really wanted to work in the community clinic. And so I was lucky enough to get that. And in that phase, that program allowed people, instead of accumulating hundreds of thousands of dollars of debt, it actually gave you tuition and a stipend to live on. And so, and in return, you owed time. And so I was, when I finished med school and then finished residency, I was lucky enough to find a position here. And it's not easy for an OBGYN to find a position at a community clinic because although, there are not very many that can support it, and La Clinica was big enough and ambitious enough at that time to really commit. There was another OB here, and so I joined then, and it was exactly the practice that I had been looking for, and the collaboration with it was primary care focus, collaborating with family practitioners, nurse practitioners, physician assistants, and really being in a community. And so that's how I got here. It really fit what I had hoped to do, and then it just kept fulfilling that.
So interesting that you talk about the kind of the social consciousness of the time that shaped it. Was there like a particular moment, experience that you had that really kind of shaped that for you?
Well, I was a bit of a science nerd anyway, so the science, the biology of development and reproduction always was really interesting. But I was actually reading a feminist book when I was doing my marine biology, and it just clicked. And then also one of the people I'd worked with back in Maine was connected to a woman who helped write Our Bodies, Ourselves.
Oh, cool.
And so I just saw all of this movement sort of different parts of it stumbling onto other parts and forming a critical mass that was really fascinating. So,
do you remember what the book was?
Yeah, it was called Women's Consciousness, Man's World by Sheila Robotham. She was a British feminist.
Amazing.
I tried to get the book. It's out of print because I thought I'd lost my copy, and I unearthed it about a month ago and was trying to go back into that. But anyway, it just really crystallized. This is where women need to really start to regain a sense of their the current word is agency, but their power really, and it's proven to be so meaningful to work with women. I think one of the branches that you take in a career is whether you go into in medicine is maybe you go into more policy and higher up administrative things, but to me, even after 37 years, getting in the room and closing the door and being there one-on-one with someone is, to me, the best piece and the most meaningful part. So, and to see women learn about themselves or teach me at the same time over the years, many times. So, yeah.
You mentioned that it was hard for OBGYNs to find spaces in community clinics. Can you tell us a little bit more about that?
Yeah, so OBGYN, when it was a very different specialty when I finished med school. To pick to go into that was a little dicey. I thought it was maybe 50-50 I'd be able to do it because it was seen as a surgical specialty, not really primary care. It was about 90-95% men. And because it was a surgical specialty, very high salary also. And people who chose to go into it really were not focused on primary care in general. There were a few people who were, but it didn't tend to attract those people. So, and a lot of community clinics, the idea of taking on, even though the salary of an OB here is maybe half of what it is in other places, it's still a lot for a clinic. Most OBGYNs want to do hospital work also because that's what you spend so many hours of residency learning to do. And a lot of clinics, I think, didn't want to take on that connection to the hospital. Unfortunately, La Clinica was already doing that, and it was just a really beautiful piece to be able to do all of that.
Mm-hmm. So when did you come to La Clinica, or were there other clinics that you went to before that?
No, I came straight here. It was an interview process. It went for the National Health Scholarship Program, which I think I said, if I didn't before, Ronald Reagan killed in 1980. And I don't think it's been resurrected in the same form, which is really tragic. But I had a list of places that qualified. So every year the feds decide on what areas have most need and kind of rank them. And within a certain range, then you have those choices. And so I interviewed in a clinic in Washington, Eastern Washington. I think the clinic's still there, and I can't remember off the top of my head the name. But I interviewed there. I interviewed in New Mexico, and I interviewed at a couple of places in the Indian Health Service too, and here, and a place in Chicago and a place back east, and this was my first choice by far, and
So what year was that?
Oh, 87.
87.
Yeah.
So how long have you worked at Clinica, sort of?
So my commitment was 2 years, and I'm here now, and that's 37 years. I officially retired about a year and a half ago, but I'm still doing substitute work in clinic. I was here Tuesday, and I had been doing some hospital work still, too, until recently. Yeah, so quite a while.
Experience.
Can you tell us, since from 87 to, more recently, like how your experience at La Clinica has been, how it's changed, what have you noticed?
Yeah, that's a big one. So when I came, we were in the building on 1515 Fruitvale, and the women's department was the downstairs of that building. The providers, usually there would be 2 at a time in the provider room and 2 medical assistants also. And they would take the triage calls. This was sort of under the radar because it probably wasn't kosher even then, but it definitely isn't now. It's not how we do things now. But they would just get on the phone, talk to someone, and then look over their shoulder and ask you what to do, and if the person needed to come in or needed to go to the hospital or what to do. So triage happened in a very informal way. And we always had an integrated practice with the family medicine doctors and PAs and NPs. It was a much, much smaller place then, and we could meet all in one room, and we had regular meetings. It was almost like a family feel. I felt very warmly received in a way that was impressive to me, being a gringo. Very, very loving community, and the people who I came to work with were, several of them had been here quite a while, several years already. And I was sort of new kid on the block, and also fresh out of training, and also learning Spanish, because I had borderline Spanish. It was very hard to find bilingual providers then, especially a specialist. The other OB didn't speak Spanish either. So fortunately, there's a good sense of humor in the team, and so we got me through that phase. And it was really well integrated with family medicine, and the hospital piece, which was a significant part of my work too, was at both Highland and Summit, what's now Summit. And it was a really interesting model for practice, which we still have, which is that the family medicine doctors do deliveries. There was a midwife also who did deliveries, but also then the OBs would do deliveries and backup for complications. So if someone had a fetal heart tracing that was bad, or had bleeding, or labor was not normal, we would be there for backup. So that the care most of the time was all contained within practitioners within the clinic. So people who'd committed to the practice and the community, which I think was just so important for patients. And at that time, the family medicine doctors were also seeing their own patients in the hospital who were adult medicine patients, admitted for, whatever, GI bleeding or heart failure or whatever. And they rounded every day. And we rounded every day and took call 24 hours, and covered the whole week and weekends and everything. And I think, you could feel it when you walk in a room and there's a woman there in labor and she sees someone either she knows or who addresses her and speaks with her and communicates with her in Spanish. The anxiety goes down. There's just this sense of comfort and, yes, I can do this and I've got a partner here. I will say the nursing staff at Summit was amazing, but it's still a hospital environment. It's very odd. And many of our women had deliveries, in home country, in Mexico or Guatemala or wherever, and so coming to a U.S. hospital was very intimidating. And so having staff from here was really, really lovely. In those days, there weren't interpreter services really either. It was very hard to get people to interpret. So that was wonderful. And we had a couple of allies in the community who also helped cover OB, a couple of practitioners who were wonderful. The other piece that I was involved with in those early days was a union, and the union has been a very big, important part of the clinic's development, I think. As you know, as you all have to do, it's always a scramble for money. It's just pulling pieces together, getting by, barely limping from one budget to the next, and trying to figure out how to make things happen. So giving raises is not an easy thing. And the way I came to see it is it's kind of an important thing to have people pushing hard at one side to make that happen. Even so, the salaries here have always been lower than county, significantly lower than Kaiser. So it's always an issue to try to retain people and attract people. So the union, there have been several strikes over the years. There have been some strike votes in recent years. But I think it's been a really important part to empower the workers here, and the entire workforce except for the administration is included. So the front desk staff, the medical assistants, and the doctors and nurses are all in one union, and I think that's been really important too. And the people who started with that and had that vision really had it right.
Mm-hmm.
So there have been attempts to split that in the past, and I think it's been really important that stayed. So that was another piece. I was on the negotiating team at one point. And then the program just kept growing. I think there was a time I don't remember what year it was with Prop 187. I think that's what you had referred to, Clara, that where there was an effort by Pete Wilson and some other politicians to take away any funds for undocumented patients, which I believe that La Clinica has the highest percent of undocumented patients at least in this region. Of any of the community clinics I know in the Alameda Consortium, we always have. And so that was just a devastating prospect, and we had many meetings to try to figure out how to continue care that would be of equal quality, whether you had Medi-Cal or not, if that came to pass, and kind of redesigned our prenatal program in a way to try to really focus efficiency on the key points of care. And that was a wonderful collaborative effort. I mean, it was with the administration, the operations people, we had a just spectacular nurse here, Sylvia Perez, who was here for over 30 years, who was a part of it and helped really implement it. Because of Sylvia's brilliance and judgment and connection with the community, we were able to implement a piece of that. She's retired now.
May I interrupt?
Yeah.
And you have given us some kind of details that are not fully discussed. Like, why did you want to serve community after graduate? Because that is something inspiring for new generation. The other is when was the time that the union? What was the beginning of the union? Because I understand you were new here, and suddenly you are in the directing the union. How was this?
Sure. So the first part of how I wanted to serve the community, I think it was just part of being a kid of the 60s and 70s. It was a time of great increase in social consciousness and awareness. It definitely wasn't anything in my family. It was something I just was fascinated by and inspired by in high school and then college. And I wasn't specifically focusing on the Latinx community, honestly, but I, in retrospect, got super, super lucky to land at La Clinica, because I've found it to be just an inspiring and generous and incredible community to be a part of. And so that's sort of the short answer maybe for the community part. But I always really believed that we needed to change the system in a big way. And instead of doing that from the top, I really felt like doing it at the ground level. The union was started before I came, and I was introduced to it because this is a funny little side thing, but for obstetricians and gynecologists, when you take a job somewhere, you need to be thoughtful about what your malpractice coverage is, because I knew people who had gone places and then changed jobs. And if you were involved in a case where someone had sued you, where you've been, you had to have what was called a tail policy that covered you when you left. I didn't plan on leaving, but it's something that had profoundly impacted, and I've actually know people in this community who were impacted about 5 years ago at Alta Bates, where a group stopped functioning and the people left did not have coverage. And the coverage for that is tens of thousands of dollars a year, I believe. I've never had to get it, fortunately, but so I was inquiring when they were hiring me here, what is there a tail policy? And no one knew, and they directed me to the union person who had never heard of it before, and then looked into it and said, yes, you're covered, it's in the contract. And so I just knew through that the union actually was the place people got directed to really find out what their rights were. And I think that the other obstetrician who was here the year before me had actually used the union to help her advocate in some kind of a issue. So the people had started it before. I don't know if Cotty Hendry was the initial organizer. There is someone still here who was in that era and very involved, Rosa Villalobos. She's in material management. Have you talked to her? Yeah, Rosa. So Rosa might be able to give you more detail on the actual how it started, but when I joined the negotiating team, it was probably 88 or 89. We'd meet in someone's living room and just do strategy sessions, and Cotty was part of that, and Rosa was part of that, and I can't remember who else is there now. Sandra Camacho now is very much involved in that. I don't know if you've spoken with her. She's a nurse here, who's been here since before I came. So, yeah, so it was small then, but it was already happening, and people already had that concept that everyone should be in it together. Cotty Hendry was a family practice doctor. She lives in Canada now, but she decided to go somewhere where there was universal health care after doing her work here. Yeah.
You mentioned earlier that you sort of landed in clinic. I got really lucky, but did you know anything about the history of the clinic before you came, or did you sort of learn it while you were here?
No.
About its
I had been buried in my 100-hour weeks in residency, and it was really, really kind of dumb luck. I mean, I think when I interviewed here, I realized that it was a very special place. Jo Billington was here. She was a manager of the whole medical department on Fruitvale at the time, and I don't know if she still works at Berkeley. She went from here to the student health center at Berkeley.
Oh, cool.
Yeah, Josefina Billington. Yeah. She left quite a while ago, but she was here in those years, and she really was instrumental in. There was a little bit of a panic the month before I came, that maybe the National Health Service wasn't going to let La Clinica qualify, and Josefina helped me navigate that. Yeah. So it was really luck.
Yeah. I also found really interesting, and it's so impressive that you sort of came and you learned Spanish. Could you tell us about sort of, you mentioned some of the kind of learning curves of, working with the Latinx community when you first came here. Can you tell us a little bit more about that experience, any anecdotes you might have?
Yeah, the classic anecdote is I'd been here probably about a month and a half, and I was asking someone, actually the National Health Service had a 2-week intensive Spanish course in Tucson in July. This summer I came, and so I went to that. And I thought I had asked all the right words and tried to memorize them on my way driving out here from Massachusetts, but I hadn't. And so I asked a woman. And usually I would be in a room by myself, and then I go out and ask for help if I needed it. But for colposcopies, where you're doing biopsies and looking at the cervix if a pap's abnormal, then the nurse would come in with me, because we needed someone to manage the samples and all, and there was bleeding. And so Sylvia was there, Sylvia Perez, and I asked the woman, por favor, ponga los talones en las estrellas, instead of estrellas. Because stirrup, I think, is estrella. It was the word I was trying to use, but I said the stars. And Sylvia, who is normally very composed, burst out laughing and told me that I was telling people to reach for the stars, and I really should not be doing that. So That was, and it had been going on for a while, so I couldn't imagine what my reputation was like in the community. And then there was a time when I felt like I was starting to do better on my own, and I came out of the room one day and I asked for help from Gloria Garcia, who's the longest serving employee here. She works in health education.
What is the name?
Gloria Garcia.
Gloria Garcia.
Yeah, she works in health education. And you should definitely speak with Gloria. She is of the community and has been here probably since 71. I don't know. I came out of the room because this woman was talking about something in brujeria, and the story she was saying wasn't making sense. And Gloria's like, yeah, it doesn't make sense because she's talking about brujeria. She came in and helped me kind of untangle the story that the woman was telling me. But yeah, they're different points where I would really need to lean on people for help, and go home at night and just have my brain would be just pinging with dissonance of trying to get from one language to the other, but yeah.
Yeah, that's so interesting. We would love to know as well, from that early part of your time here at Clinica, what were some, the health issues that you were encountering in the Latino community here, like mental health, how did these HIV/AIDS and N1H1s, can you tell us a little bit more about
Yeah.
as a physician?
So in 87, 88, HIV/AIDS was becoming, or had become a huge, we were just in a crisis in the health community about it. I would say it seemed like it came into the La Clinica a little later than some other places, and to the women in particular, but we had a woman patient who had AIDS, came in and had been a victim of abuse for a few years. She was developmentally delayed. She was living, with minimal support, parents working, and anyway, her story was just one. She was discovered because she got pregnant, and the clinic just started to piece together care for HIV positive people here, and to try to keep their care centered in the community as much as possible. Some of the testing and the different medications and all of that evolved so much. Those first few years we really leaned on other specialists too, but we also were attracting family medicine doctors who trained at UCSF and worked at the San Francisco General, where they were so competent and so familiar and so unintimidated by taking that on. And so I would say it was those people who really brought, Paul Byard was one, Patricia Zayas was one. I don't know if Patricia's name has come up, but Patri was an amazing family medicine doc here for 20-something years, and medical director at one point, and the whole teen clinic is here because Patri persisted with it. Anyway, they helped really support all of us who wanted to give care but were concerned we were not going to give good care, and support and develop systems here. So that was there. There were, just the kind of poverty and the immigration, the isolation of people was really different. When I trained in Massachusetts, there was a large Puerto Rican population in Worcester. Also lots of drug use. Some of the issues were, the drug use was very different because the population that we saw, most of the women were not using drugs. They were more recent immigrants. They were much more, it was more an issue of isolation, culturally, linguistically. As women, they were really isolated because often they were alone all day. and their work, even if they were working, their work was sort of in a very isolated place. The frustration in the immigrant community, I mean, I think we see domestic abuse in every community, but I think that, we often would see abuse and people not able, having so many fewer choices to get out of that situation because they were isolated and here and dependent on their partner. And then I also saw these unbelievably generous sort of family and community networks of people that was really just amazing to me, how people who had not that much would help each other out and through it. And I remember seeing a patient who had cancer diagnosed, and she was pregnant when it was diagnosed. She had a very advanced cervical cancer, never had a pap smear, came in. We see a fair number of people who come in with no care previously or very little from rural areas. And so she lost the baby. The cancer was advanced enough. She had to have surgery, an abortion and surgery right away. And within a year or two, she died. And I remember the family just taking in the community, supporting the family through that because she had other children, and welcoming us to be part of that in a way. Sometimes as a provider you feel like you've failed when someone dies, even though there's really not much to be done. But the generosity and the trust that people felt in the clinic most of the time and in us to do the right thing was really powerful. Yeah.
And that was here, or sorry, the story that you just told, or Massachusetts?
No, that was here.
That was
sorry.
Here. Okay,
yeah,
so no.
Yeah. The individual patient stories were here. In Massachusetts, it was a very the Puerto Rican experience is extremely different, and there's still people can go back and forth, and it's it's very different, and many of the community there in Puerto Rican Spanish is very different, and it was a very different experience. Here it was much more recent immigrants and in such different situations.
But may I, Carolina? There is one thing that intrigued me. You said that it was the beginning of the HIV/AIDS pandemic, and you see this first case. Would you, as a young doctor, were intimidated to be contaminated, and what were the precautions that you take?
Yeah, it was a time when I think in Massachusetts there was a lot of HIV. The testing, as I remember, and this is a long time ago, but as I remember, even getting tested was hard to do. They would. Because I remember having this conversation with someone in Massachusetts about getting a patient tested who I really think needed testing and wanted testing, a woman. And I said, well, I practically want to send her to the blood bank because if she tries to donate blood, they'll test her. And he said, no, don't do that, of course, because she could be in the window where she's not positive yet. You don't want to do that. I said, well, how can I help this person know what their status is? So it was very, very early on. And we were we were double gloving for the first time. But I think I'd been in it enough that when I came here, that part wasn't as worrisome, but I think it was in a transition period where other staff in the clinic were. Like this patient who did have HIV, the young woman, also needed colposcopy and needed some biopsies, and I think I had to be very thoughtful with the medical assistant I was working with to have her not only follow the protocol she needed with gloving and all, but to also reassure her before we went in the room and afterwards how to process and be safe and feel comfortable. So it is a long transition for both the people in the thick of it and then teaching and encouraging the whole staff in the clinic because they hadn't had the same experience.
Does it mean that you did health let's say, health education for the staff in the clinic.
Yeah, that's something that the providers always need to be doing and be mindful of. Yeah.
And the patient have some health educators too.
Yes. Now, yeah, I think at the time, I don't know how much health ed support she got directly. She got a lot of support from her primary provider, who was a physician assistant, and had a lot of support from the other doctors who were comfortable and had treated HIV/AIDS. But she had sort of what would it be? Not impromptu, but sort of patched together. We just sort of did what we could, and I think gave her good care to the extent that anyone in the late 80s knew how to give care. She did eventually die, and I think half the staff went to her memorial service. I mean, it was a really wrenching story, and and she had one child, I think. Anyway. But yeah, as doctors, we train in hospitals and clinics, and so we hit that. We encounter and have to work with those, like COVID, like HIV. We get immersed in that, and so then you bring that experience and try to help people be safe, first of all, and comfortable, and make sure we're supporting the patients being comfortable, and the patients don't feel like they're...
Sorry. Did you were in contact with the area of mental health here?
Casa del Sol.
That kind of patient?
Yeah, I believe that she was connected closely with them. That connection has been always limited by the grants they get, because their grants for Casa del Sol, as I understand it, is for people with very acute psychotic issues. And so often the kind of support we needed day to day was not really something they could offer. Some of the family medicine leaders, or someone who's worked in Casa del Sol a long time, can give you better insight into the exact tension there, but a lot of that was because of the limitations of their funding. Again, just a constant struggle for decades, right, to try to get. So, in fact, the clinic has creatively developed the integrative behavioral health program. Nancy Fasher, I assume, is still here, leads that. And so we do have counseling on site that is sometimes for case management resources, sometimes for mental health. Mm-hmm. Yeah.
You say Nancy?
Fasher? Mm-hmm. Fasher.
Okay.
She's been here off and on a long time. She was here a while and then left and came back. Yeah.
You mentioned another name earlier, and I just want to make sure. Patricia?
Zayas. Zayas. Mm-hmm. She's not here anymore. Mm-hmm. You could check with, I'm trying to think who, I could try to email her and see if she would be interested, but she was really critical in keeping the teen clinic alive and functioning, and now standing on its two legs. She had Tracy Mendez. Tracy Mendez was a operations person who worked closely with Patri, and Tracy is still in the community clinic community somewhere, not at La Clinica anymore, but she's,
thank you for telling us. It's so interesting to hear about, having just come out of a pandemic, to hear about all these other experiences. So we talked about HIV/AIDS. Were you practicing N1H1? I always get them letters confused. H1N1. Yeah. What was that like? How did it differ from the response to HIV/AIDS?
Yeah. I don't remember a lot about that. It was more of a little blip to me, especially dwarfed by COVID more recently. I don't remember too much about it. Okay.
Well, maybe you could tell us a little bit about COVID.
Wow.
What that experience was like here in Clinica. What was it specifically for your department?
So it was just such a dramatic, sudden change. I mean, I think a few people may have seen something was starting to come, but the scale of it was like something no one had ever seen. And we, unfortunately, were scheduled April 20-something, 2020, to change our electronic record system to Epic, which was just kind of a ridiculous thing to do. I mean, necessary, and yes, it's okay. I'm not second-guessing the decision. But the idea that we would be doing this in the middle of the beginning of a pandemic was just insane. So it was really just so I don't even know where to begin. For patients, I think it was terrifying, of course. Should they come in? Should they not? Trying to screen everyone. Most of the community had to go to work. You know, you talk about essential workers. That was pretty much who we were caring for. They didn't have a choice. They were living in large numbers and, you know, the housing situation. Even a year into it, I remember meeting this woman who came in and somehow got through our screeners and was coughing away in the visit, and I asked her a few questions, and, you know, she had to go to work. She lived with 7 people in a 2-room apartment, and they all worked in different places, and they were all basically sick. And her test was positive immediately, and she was pregnant, and she was trying to explain it by being, her mom told her she'd gotten cold in the night and it was just that, not to worry and go on. And so people were in such denial because of fear and because of the impossibility of really making other choices. You know, I've got to go to work, I've got to eat. We ended up with a food pantry. The health ed people, Carlos and his team, in preventive med put together, and I think at least a third of the patients I would see would, when I asked them, would take a bag of food because there was so much, you know, poverty imposed on poverty in that period. The strain from the clinic perspective and the staff perspective, it was just practically unbearable because you never knew who was going to be coming in that day. People either were sick or they were afraid. We had to take the same number of staff and screen, and finally when we got it, vaccinate. And some people were remote. I mean, it was just, when the work was harder, there were fewer of us doing more. It was really, really brutal. The people who showed up every day and did everything they could and did the testing, before vaccine and after there was testing. So there's screening, there's testing, then there's vaccination. And it's basically the same number of people, all expected to do the same thing. The dental crew, I think because they couldn't do dental work for a while, they did a lot of the testing and they pitched in and were phenomenal. So there were people doing phenomenal things. There were people being very creative about making resources stretch, but it was really, really, really hard on people.
I was pregnant at the time of COVID, so I'm sort of curious because I was very aware of what was going on in New York, how, you know, what was happening in terms of obstetric care here, being able to see patients without masks. You know, can you tell us a little bit about that?
So we had masks pretty much. Actually, I felt like our medical chief medical team kept people here safer than even the hospital staff was. I was just so grateful because we had, as soon as they could get them, we had N95s. We had people really making thoughtful recommendations of what we should wear, when, and how. At the hospital, and so we saw pregnant patients. We tried to do some telemed to minimize the number of people here in clinic, because we also didn't want a lot of transmission of patient to patient sitting around waiting or something. So we did do more telemed, but we saw, we had the same basic number of visits. We didn't do centering pregnancy anymore, which was a popular program that we've revived, but we didn't do that. The hospital was, I think, the hardest part for people. I can't imagine laboring in that time. I'm sorry.
No, it's okay.
Yeah.
Just for offering context for, that there was like a lot of fear and
there was so much fear.
Change, so I was just sort of curious about
that. So, when people came in, they would be tested. We had the most COVID patients of any practice at Alta Bates, I think, because we were essential workers and everything I just explained. So, you had to gown, you had to have a visor on, you had a mask on, gloves, and all the nursing staff did. And the visitors were limited. You had one person who could be in there with you as your team. And so it was very, very hard on people. We had some people come in very, very sick with COVID who were pregnant and in the ICU, and they all did okay, but they were very, it was very precarious. We tried really hard to push vaccines. It seemed to just go one way or the other. People were either very receptive and fine, or really, really didn't want it at all, or didn't want it till after the baby was born. And the mom community, we have a large mom community now. They also, it's very hard, first of all, to get interpreters. Their understanding of what was going on, I think, was very different. The health, their model of health and how the body works is different. And so would be a whole different kind of conversation, assuming you had someone to interpret and really have a robust dialogue.
What do you mean? What was the conversation like?
It just, I think partly because many are monolingual, mom speaking. There's not a lot, the information about COVID that was getting to other people wasn't getting through to that community in the same way. And so people would come in and really, not understand. They would have been to some party, a family-oriented kind of party, not out just drinking, but just like a celebration with no, and no masking and no real awareness of how it was being passed and how serious it could be, even well into the pandemic. So that was really painful to feel like you couldn't match the need there often, and trying to get the word out and some education out. That's an ongoing issue. We still every day are working hard to make that happen. We saw a mom speaking patient last week whose baby has multiple anomalies and was just discovered, and the specialist who was doing the ultrasound for some reason couldn't even supposedly get a Spanish interpreter, much less a mom interpreter. So when she came in to see me 5 days later, we did have a in-person mom interpreter in women's most of the time now, and she just had no idea what was going on. So it's it's sort of the same process. Again, we're trying to work through figuring out how to help the community build a body of interpreters that can help advocate in all the different ways of life they need, but especially in health. And actually the interpreting thing is important. When we went to Alta Bates, they closed labor and delivery at Summit in 2004, which was not what they said they were going to do. But they moved everyone over to Alta Bates. And we had a very collaborative department at Summit where there were a significant number of OBs who were in private practice, but it was Medi-Cal practice. A lot of African American OBs who served mostly East Oakland, some West Oakland, as well as our practice, as well as some other practices that were private. And people really collaborated well. And interpreting was something people would, get on the phone. The nurses were used to it. It was, we had sort of shown them, if you can't, I don't speak Cantonese, I don't speak Vietnamese or Arabic, so, you use a phone interpreter if you need to. You don't just treat someone without language. When we moved to Alta Bates, it was starting from scratch with all of that. Being in Berkeley, I thought, Berkeley, this will be a very progressive place. It was not at all. And we had to start kind of from scratch. It was a bit of a contentious transition to shift everyone from Summit over there. And teaching the nursing staff, the social work staff, everyone, how we use that and how we function. And I think we, in our practice, have gotten a reputation and a respect from the community there that's really, really impressive, and that really helps our patients, and that the staff now chooses to take care of our patients. Like when they're giving out assignments at the beginning of a shift, they want to take care of La Clinica patients. They know they've gotten good care, and they know they can partner with our providers during their labor or their admission for whatever reason.
Interesting. How was this transition from here? I don't get it well.
Mm-hmm.
You said that suddenly you were, correct me if I am wrong. You said that suddenly you had to go to Berkeley to work over there for the transition.
Yeah.
How was this?
So this was a political piece of medical care where Sutter bought a couple the hospitals in Oakland. I think there had been a Catholic hospital, Providence, and another private hospital, Merit, that merged. And a few years later, Sutter came in and bought Alta Bates, and then they bought Summit. And at that time, they said they would keep OB services and emergency services and basic services in Oakland, which is where Summit is. Within 2 years, they said, sorry, we've changed our mind. We're going to move all the OB. So that meant all of our patients traveling further to Berkeley for their care, and disrupting a department that was at a scale that was very, like I said, collaborative, and the care was very good there, actually. So it was a decision that was made by the company, by Sutter, to consolidate in Berkeley.
You have Summit, the insurance you're talking. The Summit is an HMO or something like that?
No, Summit is just the name of the hospital in Oakland.
Okay.
And it was a private hospital, I guess community owned. I don't know exactly who owned it before, but Sutter, who owns a lot of hospitals in California, bought Summit.
But what I don't understand is the link between you and
Summit. Because our practice was, we delivered all the babies and did all the inpatient medicine at Summit. And so that was, they kept arguing, it's only a few miles down the road, but it was in Oakland. It was easily more accessible, and the culture of that medical community was one that was very supportive of the community and Medi-Cal. But Medi-Cal patients weren't looked down on, whether they were Black, whether they were Latinx, whether they were Asian. Medi-Cal and private patients were cared for together, and the doctors who cared for them and the nurses who cared for them equally. So there was a very different culture actually at the time at Alta Bates. That has shifted some, but we did a lot of advocacy and how to sort of retrain a lot of the staff and demonstrate to people that patients who are poor should not get poor care. And they should get it in their language.
That's an important concept.
Yeah, and so I think the story at La Clinica is in so many ways. I'm sure you've heard this from Jane too, when they asked us to go out to Contra Costa or they asked us to go to Vallejo. It's trying to take on again a place where the expectations are very different. the culture is really different, and to, demonstrate, advocate, persist, basically. Yeah.
I had one more question about, you mentioned in the early days the midwife care. Is that something, a program that's continued in Clinica, or was it something just in the early days?
Yeah, good question. So we had midwives. Usually it was just one midwife, and they would work in clinic, and they would also deliver babies, obviously, and integrated in a schedule with the family medicine doctors for normal deliveries and labor. I think it was about 4 or 5 years ago. I think it was before COVID. I've lost a little track of time. COVID distorted it so much. The last midwife we had resigned to go join a bigger group of midwives. And the decision was made to not look for another midwife, I believe this is right, but to look for someone who was family practice, because they can take care of anybody. Kids, adults, men, women, they have a broader scope, and because the clinic supports a primary practice that's very diverse and has a lot of needs, and the flexibility of having a family medicine doc was I think that's what happened. But the family medicine doctors and the midwives who had been here have really advocated for and made the OBs really tone down some of our training of intervention into things that are less intervention and very supportive, patient-centered. Yeah. So I feel like, although I miss that influence, I wish we could have it. I think it was one of those where you just needed the extra people in clinic who could, yes, I can see a kid who's sick at the last minute, instead of someone who's a midwife and had very limited could only see women who are basically healthy. Yeah.
Sorry, I'm still reflecting on this midwife question. I'm kind of wondering whether if you've noticed the culture of care changed after midwives have left.
Yeah, I don't think so. I feel like we have nurse practitioners who have that nursing perspective in their practice, who are amazing, and I think that the centering program is revived. That's very much aligned to me with midwifery philosophy of care. So I don't think it shifted. I mean, in an ideal world, I think we would have a few midwives who also could support when the family medicine people come out of their training and start practicing. I think it would be nice for them to have not just OBs to step in and help them, but to have a midwife model functioning. But I don't think I just think right now it's probably not practical.
Yeah, okay. Would you mind sharing with us any personal stories or experiences that have illustrated or demonstrate the life-changing impact, sort of profound impact of the health services that you've worked in within the Latinx community?
I'm not sure what you mean.
Any experiences that you had that kind of should give us an insight into what impacts the care that has the Clinica or that you've provided here through Clinica have had on Latinx families or the community broadly?
Yeah, I mean, I think there are multiple levels of impact. I think that we see people, I mean, you see it sort of almost every day when you walk in the door here. I see women here, even as I'm here very regularly now, who I've taken care of for 30 plus years and who are grandmothers now, and who, when I first saw them, was one in particular who had a baby with severe fatal anomalies with her first pregnancy. And I remember telling her that and coaching her through the the labor, and she's now a grandma, has 3 grown kids, and sort of through all of those experiences to be a constant there and have, again, that trust that is just so humbling is really amazing. But I think that what we provide with that kind of continuity, and yes, we're here for you, is really powerful. We see women who've been in abusive relationships who, you keep seeing people back month after month or year after year, and then finally they have left and they have a new life. And, they had support here when they needed it. They had someone who really treated them with respect as opposed to abuse, and had a sense of what that felt like. I don't want to overstate what influence the clinic played in that, but I have to feel that it played some role in that. And I think, we had a receptionist here for many, many years at the front desk in women's, Soledad Guzman, and Sole, when people walked in that waiting area, even though they knew they may have to wait quite a while, Sole would just, I think when you talked to her, you could relax. You knew you were going to get taken care of from the very front desk onward. And that happens also at San Antonio. I don't know if you've interviewed people from San Antonio, but...
Not yet.
Okay. And it's not as much only Latinx, so maybe that it's very much more complicated. You can easily be in and out of 5 languages there in a day, so very complicated. But I feel that model of community-based care has just been validated again and again and again in so many ways. We have people coming, who were born and had care in the pediatric practice here, who have come back to us for their pregnancies and are having their family with us. It's very humbling and gratifying, sort of in combination. Really powerful. And there are a couple of nurse practitioners now who work here who grew up in the community. So the other thing is this transition. I mean, we've been hoping for years to really recruit more Latinx providers as well. And we have some, but, it's a long transition to get through the training, the debt, to then take a job that pays less, even with loan repayment. I mean, it takes a while to make all those things come into place. And we have 2 amazing nurse practitioners. Norma Ruiz, she now works out at Concord. She's phenomenal. I think she's been with us probably 5 or 6 years now. But she got care here as a child. She went to the nurse practitioner program at UCSF, and she came here, and she's just brilliant and amazing and raising her own family. And Catalina Gonzalez, who's a nurse practitioner now in women's, is from this community too, and was a nurse for years and then went back and became a nurse practitioner. And so that also is super rewarding. Some of the other staff we have who've been here and grown in their positions, I mean, that's another piece that's very rewarding, is it's the community as a whole. A huge piece of that, of course, are patients, but then there's also the staff, and seeing growth and people really hitting their potential or seeing more for their kids too.
And at all those experiences compared with what you thought at the beginning to serve at the community, do you think you achieved your goal or serving community? How do you feel about it?
Yeah.
37 years after?
Yeah. I feel just incredibly blessed, because I feel like I can't speak to how much the community feels like I impacted, but for me, I feel like I couldn't have been in a better place. It's just been so gratifying. It hasn't been easy, Both my daughters are going into healthcare, So I think that although I felt like I complained a lot at the dinner table, and after call and being up all nights and working weekends and stuff, one is a family medicine doctor and one is going into family nurse practitioner, and both in primary care. And so I feel like, I think this is the best place I possibly could have been, and I'm very grateful to the community that I could play a role here and be accepted and trusted to do that. Yeah.
And what is your message for this new generation that we wanted to train, to educate in the need?
Yeah, I'm really inspired by the new people coming out. I'm fearful because the climate is so difficult. You know, COVID really decimated in many ways, I'm sure many different professions, but the healthcare really took a hit. I think people got scared, people felt like they weren't being protected and centered, both patients and workers. Places that pay more are even having trouble recruiting, and so you can imagine what it's like here. It's really hard. The electronic record has created enormous amount of extra work that nobody's figured out who should be doing and how to make that happen. People, charting after hours or just not charting very well, or people, it's a very different world. So I hope that they will have the same gratifying experiences and be able to center themselves with the direct care. And I think it's possible. Probably the electronic record thing will sort itself out because people are so much more computer savvy. I didn't grow up with that, so it's clumsy for me. Right? It's so clumsy for me. But I also see my daughter struggling some with it, but I think they figure ways around. So probably that piece will recede and not be as big a burden. But yeah, there's a lot that we have not addressed in healthcare that I really thought would be different now. I really thought we would have a single payer or some kind of national healthcare at this point. Yeah. It's been years. I remember standing in front of, I don't know if it was Home Depot or someplace in Richmond, my first year or two out here, trying to get signatures for single payer, and here we are.
Yeah, this is a fight. Still is very difficult, but you need more people to get together.
Yeah,
because the intent of some healthcare providers have been decimated by the politic.
Exactly. Yes.
Yeah.
It's so powerful. I mean, I think the companies involved, the lobbying interests, have only gained more and more power. The insurance and pharmaceutical have gained so much power. It's very hard to imagine how it's going to change. And I thought, almost anyone you speak to has a story of how the healthcare system is not working for them or their family. So that was true 40 years ago. So I don't understand.
Yeah.
But, well, I'm sure it's money.
Thank you, Carolina.
As you reflect on your career, as we've been talking about it, what do you think are maybe the biggest challenges that you've had in your career here, but also what are your significant success stories?
Mm-hmm. Yeah, I think the biggest challenges come down to a couple things. One is the systemic issues in our healthcare system and our society. So it's both how healthcare is structured and poverty, and not to mention attitudes towards immigration, which have become more and more astounding and challenging with Prop 187, believe me, that was very, very intense too. But it's really perplexing to me. So those, and the other thing that was challenging is, I think, as training in OBGYN and in medicine in general is not really didn't really equip me to be prepared for some of the challenges in terms of supporting a practice and developing a practice. You know, the administrative parts, the logistics of how to develop a practice were things I didn't have. But the successes and the rewards, besides the patients, which I think I've spoken to, you know, the colleagues here have been also phenomenal. In family medicine, and the nurse practitioners, Rosa and I were good friends. We have kind of lost track a little, but there have just been some really powerful connections and people who've inspired me, and people lean on each other a lot. And when you get into a little more of a leadership position within the clinical areas, it's just a phenomenal group. I used to be really inspired in those meetings by listening to people brainstorm, how are we going to do this, but what about that, and listening to each other and really trying to create solutions. And some of the operational people and higher up administrative people are just really, really dedicated, and that's, even though we don't always see eye to eye, you have a very different perspective in a clinical situation. We know that the intent is the same moving forward, and
help.
And supporting the community, yeah. So I think this is also a time there's been a lot of transition of people who've been here a long time to the newer folks, and in the clinical area anyway, I feel like it's going really well. There's some really great people here to carry on, yeah.
Mm-hmm. I have my one last question, but
no se me ocurre.
No, just to wrap up, we want to ask you, what has it meant to you to work at Clinica for how many, almost 40 years?
Yeah, it's well, it's hard to let go of. So I will say that although I retired, someone told me the other day I'd failed retirement, but I love it. So I do continue to work part-time. I didn't want to take up a position because we really needed someone who had the energy and the vision and the everything to come in and take that position. But it's I couldn't have written it better. Even at my this was hit me with I went to my 50th high school reunion a few years ago, and I said, I've kind of lived my dream so far. This is really, when I read that book by Sheila Robotham in 1977 or 8, that's what I decided I wanted to do. And fortunately, this community and the people who've created the clinic were, helped me live it out. So I hope I get to keep, contributing in whatever ways.
Just want to, before we wrap up, ask you if there's anything that you would like to add or that you feel like we should have asked you before we finish.
Yeah, I can't think of anything right now. It's I might think of something later and I'll email you if that's fair.
Yes.
But I can't think of anything now. I wanted to make sure I mentioned some of those names because there are people here. I mean, it's really takes a village. It really takes so many different pieces to make it happen. And the other thing that is amazing about this place is that the vision from the beginning, this I forgot to bring in, to have the lab and pharmacy, dental, mental health, health education, to have these things all together is just so powerful. You cannot imagine not having what it does to not have a pharmacy. And the pharmacists here you have to talk to Dolly Devar, who's the head pharmacist. She's been here for 10 or 15 years, I think. And I don't know where she finds them, but you call down there and you have a patient at 5:15 who needs an antibiotic, and it's really important they get it, or they've been confused and their diabetic meds are messed up and they need something right away, or asthma, something really urgent. They will answer the phone, they will figure out what they need, and they will get it to them. you can spend, I don't know how long it will on the hold at Walgreens or CVS or wherever. And even though we have sort of a collaborative relationship with one of the Walgreens, it's just so different to have people understand and partner with you. And in all those areas, you know, in preventive med, in dental, in the lab. The lab is a little wobbly at the moment, but basically having a lab there too. People don't have to go find a lab somewhere, and it's phenomenal. Yeah. So.
Well,
yeah.
Yeah, no, thank you for your time. That was
Sure.
amazing. Thank you for
It was lovely.
sharing all your stories with us. And yeah, thank you again so much.
Thank you for doing this and for your work. It's so important, and it's so important to get the word out.